morning and welcome to this webinar. I'm Yassir Javaid, GP with a specialist interest in cardiology, and we have a wonderful array of experts to discuss the critical importance of the early detection of atrial fibrillation in the fight against strokes. We know that cardiovascular disease is responsible for over a quarter of deaths in this country, but it's stroke that is often the most devastating of all cardiovascular events, with catastrophic levels of associated morbidity and disability, as well as high mortality. And out of all cardiovascular events, AF-related stroke is the most preventable. And for me, AF management, particularly in primary care, is simply a race. There are so many patients out there unaware that they have this ticking time bomb of a condition. And our job as clinicians should be able to detect these patients, offer them anticoagulation before they present with that catastrophic stroke. Sadly, though, stroke is winning this race far too often, and clearly timely diagnosis of AF remains the biggest challenge to address the unmet need. Let's look at this sad but tragically common case scenario of a 68-year-old woman, previously fit, active and independent, enjoying the early years of retirement, presenting with all the signs of an acute stroke, and her emergency CT scan confirming a massive left-sided area of infarction with horrible midline shift, classic of an AF stroke. And AF is responsible for around a third of all strokes and has become established as the leading independent risk factor for stroke, increasing the risk by an average of 500%, much higher, for instance, than the risk associated with hypertension. AF detection is reassuringly a key component of our current NHS long-term plan and is identified as one of the biggest opportunities to save lives and prevent health inequality over the next decade. Frighteningly, it's now thought that 1 in 3 adults who reach the age of 55 will eventually develop AF in their lifetime. It must therefore become really routine primary care clinical practice to pick up these patients, and the burden of AF, we must also remember, will increase sharply in the coming years as the population continues to age. Although, as you can see from this graph, men have an overall higher prevalence of AF, you can also see that women tend to catch up in their later years. And we also know females have a higher stroke risk when they have AF, as highlighted in the CHADS-VASc scoring system. So sadly, our patient had a devastating outcome, likely now spending her last few weeks, possibly months, in a nursing home, not being able to speak, swallow, or move half her body, and is now wheelchair bound. A truly horrible outcome. And the tantalizing question I want us all to have in the back of our minds during this webinar is whether this horrible event could or should have been avoided, particularly with the use of some innovative technology that is now available. With us tonight, we have Professor Faizel Osman from University Hospitals Coventry and Warwickshire, and Lucy Gilbert, Innovation Lead in the team of Professor Osman, and Dr. Barry McDonnell from Cardiff Metropolitan University, with whom we will have a closer look at what the ESC guidelines tell us about the diagnosis and management of atrial fibrillation. So then we'll follow up with looking at how we can translate the evidence and guidance into routine clinical practice. So let's kick off now with my good friend, Prof. Osman. Can you please explain, Prof, what the ESC guidelines, the current European Society of Cardiology guidelines, state about this important topic?
Thank you very much indeed, Yassir. It's a pleasure to be here with you talking about the ESC guidelines for atrial fibrillation. So I'm a cardiologist and electrophysiologist here at UHCW in Coventry, and also working with Warwick University. So the European Society of Cardiology guidelines for atrial fibrillation are a very, very comprehensive and useful set of guidelines. The ESC have really provided guidelines over the last 15, 20 years and have regularly updated them. And the last update was in 2020. And one of the things that's actually very helpful about the ESC guidelines is that they are updated very, very regularly. So it would be interesting, I guess, to find out how many people are aware of these guidelines.
Yeah, let's have a poll on
So
that. So if we can have some interaction from the audience, how many of the audience are actually familiar with the latest European Society of Cardiology guidelines on AF? And if you look below your video player, you should have the option to give your answer, and we'll give you a few minutes, not a few minutes, a few seconds to input your answer, and it'll be quite interesting to see what the results are. Faisal, while we're getting these results, can you explain to the audience how you perceive the European Society of Cardiology guidelines? I mean, a lot of cardiologists I speak to tend to use them as a sort of reference guide. In your opinion, is that correct use of them?
yeah, that's a very good question. I agree. I think they are a very good reference guide. There are other guidelines, of course. Here in the UK, we have the NICE guidance as well that's been updated recently. I think the beauty of the European Society of Cardiology guidelines is that they are updated frequently. They incorporate all the latest data, and it's a pan-European, very often American specialty that that actually makes up the core of the people that write these guidelines. So for me, I would say for me, they are the gold standard.
Fantastic. So let's see what the audience have inputted in terms of their familiarity with these guidelines. Can we get the poll responses up on the screen? Do I have to... Nope. Have we got the results? Have we got the results? Yes. So I can't see those. Is that 100%? Yeah, so 100%. It seems like 100% of the audience, Faisal, that's quite reassuring, are actually familiar with these guidelines.
Yeah, no, that is very, very reassuring. Absolutely,
Fantastic.
absolutely. And Pat, and so now that will hopefully make life easier. So I'm just going to run through some of the background around atrial fibrillation. So the audience out there, and will be very familiar with some of this data. We know that AF is the commonest arrhythmia worldwide, and certainly in the Western world. We also know that the prevalence and the incidence of atrial fibrillation is rising. So over the coming several decades, we are going to see more and more atrial fibrillation. As you quite rightly pointed out, AF does increase the older we become. It is more common in males, but females also have a slightly higher risk of stroke from atrial fibrillation. And something that's quite startling is that if you're in your 50s and you're in a room full of people, there are 3 of you in total, there is a 1 in 3 chance one of you will get atrial fibrillation. And that's quite startling when you put it in those terms. So it really is an arrhythmia that affects the whole community, and we are going to see more and more of this arrhythmia. In terms of the classification of atrial fibrillation, this really has remained fairly unchanged over the last several years, and we have the classification of paroxysmal, where AF comes and goes by itself, usually lasting no more than 7 days, typically terminating within 48 hours. Persistent is where atrial fibrillation lasts beyond 7 days. Long-standing persistent atrial fibrillation is where AF lasts for more than a year continuously, and permanent is where it's accepted that the patient has atrial fibrillation, and both the persistent atrial fibrillation, and both the patient and the physician have accepted it, and it's there all the time. There is this entity of first diagnosed atrial fibrillation, and patients can, of course, have a first presentation with either paroxysmal, persistent, or permanent. There are certainly certain terminologies that are now not used as much, and the guidelines suggest that we should perhaps avoid them, and they are terms such as lone AF, valvular, non-valvular AF, and chronic AF, because they do generate some confusion. So why is AF important? And again, you very nicely highlighted, Yassir, some of these. We know that patients can present with symptoms, and that impacts significantly the quality of life. Typically palpitation, breathlessness, fatigue, but other symptoms can also occur that can result in hospitalizations. Importantly, a significant number of patients can be completely asymptomatic, so they can be at risk of all the problems of AF and not even realize they've got it. And that case that you highlighted of the lady who had a devastating stroke, again, if somebody has AF not realizing it, that can be potentially life-changing. We know that AF is associated with some very negative outcomes. There is an increased risk of mortality. We know also that there's a higher risk of stroke in these patients. We know that there's a risk of LV, left ventricular systolic dysfunction, and heart failure, increasing recognition of dementia and cognitive decline. There's also depression because of the symptoms and the quality of life that is impacted. Patients having recurrent admissions to hospital and hospitalization, and that's a huge part of it as well. And of course, that has a huge burden on the finances of healthcare providers as well. So all of those things are very, very important, Yassir.
Okay, so that's really helpful. You mentioned, Faisal, I can't help asking this question, that there's certain terminology we shouldn't use. In primary care, I often see this terminology of AF resolved, or this read code of AF resolved. Can you truly resolve AF, particularly when it comes to stroke risk?
So that's a very good question. I think atrial fibrillation, it's a spectrum of a condition. So very often starts as paroxysmal and then can transition into persistent. And clearly there are things we can do to delay that or slow it down, or to try and prevent it from recurring back. However, as you'll see in the coming few slides, atrial fibrillation, sadly, is a condition that becomes more common the older we become. And as the heart becomes older, develops more fibrosis, becomes a little bit more dilated, atrial fibrillation is likely to come back. And there are several things you can do. There are medications we'll talk about. However, the risk of atrial fibrillation is always there, that it may come back.
Always.
So I always hesitate to use the word cure atrial fibrillation. I prefer the word treatment rather than cure.
Fantastic. And you mentioned that the ESC guidelines update very regularly, far more regularly than perhaps our national guidelines. What's new in the latest iteration of the ESC guidelines in relation to AF management?
So you're right. The European Society of Cardiology do update the guidelines much more frequently, and I think that's a very helpful thing to do, because it takes into account up-to-date trial evidence, and actually that can be incorporated into practice. So in the 2020 guidelines, there are a few things that are new and that have been updated. I've tried to highlight here in red. So the ESC recognized that atrial fibrillation now can often be diagnosed by patients themselves, because nowadays people have smartphones, smart watches, smart devices, even blood pressure monitoring devices that can record heart rhythm. And they often have a single channel recording. So in the past, we'd certainly say that atrial fibrillation, you'd need a 12-lead ECG, but recognize now that actually you can diagnose atrial fibrillation from a single rhythm strip, and the guidelines talk about having 30 seconds or more of an irregular rhythm with no regular atrial activity or P wave that is seen, and that can be diagnostic of atrial fibrillation, and that's very, very important. So this slide just shows what sinus rhythm would look like. You have clear atrial activation, a clear P wave before each QRS complex, and the QRS interval, the RR interval, is regular. However, in atrial fibrillation, there are no discernible P waves, and the QRS activation, the RR intervals, are completely irregular, and that is diagnostic of atrial fibrillation. So what else is new in the guidelines? So I think very helpfully, the guidelines now also talk about risk factors for atrial fibrillation. And these slides highlight some of the risk factors that can be associated with atrial fibrillation. We know that there are some things that we can't do anything about: aging, genetics, male gender, and ethnicity. However, there are a lot of things that we can do something about. So patients who have comorbidities such as hypertension or diabetes, people who are overweight or obese, we know that impacting, controlling those things and improving those things can have an impact on the atrial fibrillation. Other things such as obstructive sleep apnea, and there's a lot of recognition now that obstructive sleep apnea is associated with atrial fibrillation and can be. Alcohol and smoking, again, lifestyle choices. It's important that everyone is aware that these things also impact your outcome in atrial fibrillation, and hyperlipidemia. So again, a recognition there are a whole host of things that we can do something about to reduce the risk of atrial fibrillation. Now, the guidelines also talk about identifying lifestyle changes and tackling weight issues. We also know that, particularly when it comes to atrial fibrillation ablation and treatments, the risk of recurrence is higher if these risk factors aren't tackled. And the guidelines now talk about tackling those risk factors, particularly when it comes to therapies such as AF ablation. And there's also a recognition that actually opportunistic screening can also be very, very helpful and very useful when we're talking about atrial fibrillation and ensuring that we try and identify those particularly at risk with opportunistic screening, particularly those that have hypertension. So we know, as I've touched on previously, that there are a number of screening tools that are available. We're all now wearing a lot of devices. I have an iWatch now, not that I'm advertising for Apple, but we all have devices that we're wearing. We have smart watches, smartphones, and we are going to be picking up more and more atrial fibrillation. And again, the guidelines recognize that actually there is going to be a higher awareness by patients. And they talk about opportunistic screening in people who are 65 or more, and perhaps having a more systematic approach in those that are 75 or more, where we know the risk and the complications associated with AF are higher. We know, obviously, from the guidelines that to make a definite diagnosis of AF, you need a 12-lead ECG, but the guidelines recognize that with these new devices, that often it'll just be a single-channel ECG recording. And again, they very usefully have said that actually 30 seconds or more of something that looks like atrial fibrillation is then enough to diagnose atrial fibrillation. And so with that, I'll hand back to you, Yassir.
Yeah, well, Prof, I mean, let me put you on the spot. Are you happy to make a diagnosis of atrial fibrillation with a trace that a patient has recorded in their living room, a good quality one-lead ECG trace, 30 seconds of atrial fibrillation? Is that enough for us and for you to diagnose atrial fibrillation to the point of perhaps starting anticoagulation?
A very good question. I think the answer to that, Yassir, is yes. I think the key word that you use there is good quality tracing. So if there is a tracing that is actually not good quality, and you can't actually make any head or tail of what's going on. The key thing is you have a good quality tracing. You have 30 seconds of it. You can clearly see that there is irregularity in the RR interval that is throughout that 30-second period, and actually that there is no discernible underlying P wave. And I think based on that, you can, I think, confidently say that this patient has had an episode of atrial fibrillation. Now, clearly, if it's persistent, you can confirm that with a 12-lead ECG, but you won't always have that, of course, and patients may have paroxysmal atrial fibrillation, where the AF terminates and you just don't see it again. So I think if you have the technology, you can capture that rhythm at the time of the symptoms, and it is a good quality tracing and conforms with atrial fibrillation as defined by these guidelines, then absolutely yes.
I mean, that's fantastic. That's really going to open up the scope for picking up a lot more incidental AF, which is actually moves me on to the next question. A lot of these devices are going to pick up AF that's completely subclinical, patients completely unaware of that rhythm. How do we manage those patients? Is the management different in those patients?
So again, another very, very good question. So the management of atrial fibrillation is also very, very clearly laid out in the new ESC guidelines. And they have quite a nice 4S approach that these slides are taken straight from the updated guidelines. And they talk about the 4S approach. The first being stroke prevention and assessing stroke risk using the CHADS-VAS scoring to assess symptom severity. So how bad is the atrial fibrillation using some sort of symptom scoring. The guidelines talk about the European Heart Rhythm Association symptom score or some sort of quality of life assessment. Assessing the severity of the AF burden. So how often is the AF happening? How long is it lasting for? What are the temporal trends? Is it paroxysmal? Is it persistent? Is it long-standing persistent? And the final S is substrate severity to try and gauge an idea of the underlying substrate. Is there an atrial cardiomyopathy? And very often comorbidities are important when assessing that, such as hypertension. And several clinical assessments using history and examination, but also imaging such as echo, CT, MRI can help with that substrate assessment as well. And again, when we talk about integrated management, I think these two slides are very, very helpful. They show very clearly that the patient is at the center of what we're doing, or at the top of the pyramid, that it's very important that we think about the important things, stroke prevention. The case you very nicely showed at the start of this this webinar was of a lady who had a devastating stroke. So stroke prevention is something that we should immediately be thinking about. And of course, along with that, symptom control and management of cardiovascular risk factors and comorbidities. And all of that requires, of course, buy-in from the patient, educating the patients, talking about lifestyle modification, and actually having some possible psychological management as well, because that can help. And then having strategies working with the patient to ensure that they adhere to those therapies, and having a multidisciplinary approach where people like cardiologists, like general practitioners, AF nurses, even carers and people who look after patients with AF, as well as pharmacists and community healthcare professionals working together and having input from other subspecialties from around them to actually tell us to manage the patient and have them at the center of the focus. Coming on to the updates within CHA2DS2-VASc, again, I'm sure the audience are very, very familiar with the CHA2DS2-VASc scoring. Just to highlight that another new thing within the ESC guidelines, the C of congestive heart failure, of course, was always a clinical history of heart failure or echo evidence of LV systolic dysfunction, but there's a recognition that hypertrophic cardiomyopathy is also associated with a higher risk, and that is now incorporated within the guidelines. The guidelines also talk about the HAS-blood risk score, which again, people will be very familiar with, which assesses the risk of bleeding. And they also touch on the NOACs or the DOACs that are available and talk about the type of DOACs and the doses that can be used, again, based on all the evidence that is available. And who should be anticoagulated? Well, the answer is almost everybody. If there is a female patient who has a CHA2DS2-VASc score of 1 and it's because she's female, then you don't need anticoagulation. If your CHA2DS2-VASc is 0 and you're male, as it will be, you don't need anticoagulation. But if your risk score is 1 and you're male, you should certainly be considered for anticoagulation. And if your score is 2 or more and you're a female, you should certainly be considered for anticoagulation. So again, a push towards getting clinicians, healthcare providers to think about anticoagulation to prevent the devastating impact of strokes that we can come across. So the other thing you asked about was these subclinical features or atrial high rates. And increasingly now, patients have these devices. They may have implanted devices such as pacemakers or defibrillators, which can obviously pick up atrial arrhythmias within them. And it's a very good question that if you don't quite meet the criteria for atrial fibrillation, then actually, what do you do about those patients? And again, the guidelines do touch on that. So subclinical atrial fibrillation or atrial high rate events, as you can see on these slides, they can be difficult to manage. And how would you manage them? Would you start anticoagulation? And again, the guidelines have very usefully talked about that scenario and how we would manage those patients as well. And they talk about assessing the CHA2DS2-VASc score, which of course we're all used to doing, and trying to assess whether the patient's at low, moderate, or high risk based on CHA2DS2-VASc, but also then looking at the AF burden or the subclinical AF burden or the atrial high rate burden. So how often is the patient having these episodes of subclinical AF or atrial high rates, and how often are they lasting for? And clearly, if the burden is high and the CHA2DS2-VASc score is high, then there is a higher push towards actually giving oral anticoagulation. I hope that answers the question, Yassir.
Yeah, fantastic, Faizel. You mentioned what I want you to move on to now is sort of a brief overview of some of the new trial data. I know there's been some very impactful trial data, particularly in relation to AF intervention with ablation. But you did bravely mention, Faizel, as an EP cardiologist, as a professor in EP cardiology, you still aren't in a position to tell patients there is a cure for atrial fibrillation. So if you could clarify what exactly is the role of AF ablation in the management of atrial fibrillation. And if you could also answer from a primary care perspective, a really important question, which patient should we be thinking of referring to you for an assessment for an AF ablation?
Thanks for that, yes, and a very, very important questions that you asked there. So, in terms of the trial data, there have been several trials that have been published that have sort of come along in the last few years that actually have been very important, and I've listed a few of them just on the slide here. So, Castle AF was a catheter ablation for atrial fibrillation in patients with heart failure, and they had implanted devices in. And essentially, what the study found was that these patients with heart failure who underwent an AF ablation procedure had very beneficial effects. They had mortality benefit, and this was the first time that an AF ablation cohort actually showed a mortality benefit. So that was quite an important study published just a few years ago. There were two other big studies that have been published. The Cabana trial is an American trial, a large randomized multi-center trial looking at the effect of catheter ablation versus antiarrhythmic drug therapy on a number of outcomes, including mortality, stroke, and bleeding. And the study actually found that the arm that had AF ablation, this trial didn't reach the composite primary endpoint. However, they recognized that the actual event rate was very, very low in the trial, and there were also some issues of crossover between the two arms within that study. The latest study really that's shown here at the bottom is the EAST trial, which is early rhythm control in patients with atrial fibrillation, which was published just very recently in the New England Journal of Medicine. And this study, again, a large multi-center randomized controlled trial, primarily within Europe, that looked at early intervention, be that with ablation or with drug therapy, of having an aggressive early rhythm control strategy, and found that actually there the patients did do better with that strategy. So again, evidence suggesting that rhythm control actually is important. In terms of what the guidelines say of who should be having an ablation or who should be having drugs, I think these slides can be very, very helpful for us. Again, it's interesting to note that patient choice is actually high up there, no matter what therapy we talk about. So it's important to have that discussion with the patient in front of us, assessing their risk factors. And again, risk factors are highlighted here, as well as their comorbidities, ensuring that they're on the correct therapies, ACE inhibitors, ACE receptor antagonists, and particularly treatments for hypertension or for LV systolic dysfunction. Now, patients who have no or minimal structural heart disease, antiarrhythmics can be tried. And again, we normally start with the class 1 antiarrhythmics, drugs such as flecainide or propafenone. We also have dronedarone, which is a newer class 3 drug that's used in selected patients as well. But catheter ablation is an option, again, after discussion with the patients. Those that have preserved heart pump function but have coronary disease, again, the drugs that you're kind of limited by then are drugs such as dronedarone and amiodarone. Amiodarone, of course, is the most powerful antiarrhythmic, but is associated with some quite nasty side effects both in the short and the long term, and may not be an option really. A catheter ablation also can be considered in this cohort, and those who have heart failure with reduced ejection fraction, where the LV systolic function is significantly impaired, their catheter ablation or amiodarone. And again, a close discussion with the patient about what they would prefer themselves. And again, the key thing around ablation is that discussion with the patients. We always highlight to the patients that the reason for doing an AF ablation is to improve symptoms. So you have a patient who's in AF, they feel far better in sinus rhythm than they do in AF, but keep going into AF despite medical therapy. That may be with or without amiodarone. And there, a discussion around ablation can be very important, and particularly also in younger patients who may not want to take nasty drugs such as amiodarone, or who are taking antiarrhythmics such as flecainide, but actually don't want to take flecainide longer term. And we know from the evidence that actually AF ablation can be particularly helpful in those patients. And currently, we have two broad ways of performing an AF ablation. And essentially what we do know is that the pulmonary veins that drain blood from the lungs back into the top left chamber, the left atrium, have sleeves of muscle tissue within them that fire off ectopic beats, which then triggers atrial fibrillation. That was really discovered in the early to mid 90s. And an ablation procedure involves putting in either a single piece of kit, a balloon with a wire that comes out, pushed against the vein, blocking the vein, inflated up, and that then freezes the outside of the vein. And that freeze generates a scar which seals the vein electrically, so the signals cannot escape back out. The alternative is using point-by-point radiofrequency ablation, where we're burning tissue, and typically we use a 3D mapping system to do this. So we're putting 2 wires into the left atrium, into the top left chamber. We're seeing the signals within the pulmonary veins, and we are burning outside the pulmonary veins around them in pairs, usually, to seal them off. And that scar that's generated by the burning this time also prevents the electrical signals from getting out. And the success rate can vary, of course, between the type of atrial fibrillation. Those with paroxysmal atrial fibrillation usually have a higher success rate, in the region of 70 to 80% with one procedure at 1 year, whereas those with more persistent atrial fibrillation tend to have lower success rates, because we know that the AF can potentially come back, and we tend to quote a 50 to 60% success rate at 1 year. And some people do need to come back for more than one procedure. But again, having a very individualized discussion with them and looking at them is very, very important in talking about risks of ablation. I've just shown a slide here of a paper that we've just recently published looking at the safety and cost effectiveness of day case catheter AF ablation, which is what we've been doing in Coventry for a while, and many other authors around centers around the world have published their data as well, very much in keeping with ours, showing that this is a very safe, effective, and a cost-effective way of managing patients who have atrial fibrillation, and actually can provide a significant benefit for them. Again, when we look at the detail of some of the guidelines, it all comes down again to patient choice, and this slide tries to differentiate between those that have major, minor risk factors, and also recognizing the Castle AF trial, that those with heart failure with reduced ejection fraction, thinking about an AF ablation in those selected cohort of patients earlier. But catheter ablation, you can see, is dotted around these slides. And in terms of primary care, which is you asked about specifically, I think, again, a discussion with the patient around quality of life and symptoms and the medication they've tried. And I think early referral on, ideally, to electrophysiologists such as myself, I think is quite important, because what we do know is that the earlier we perform an AF ablation in that AF journey, the more likelihood that they will have success at 1, 2, 3 years down the line. So an early intervention is better than one that is delayed, because over time the atrium can develop an atriopathy, and then maintaining sinus rhythm can be more difficult. So really, this is a summary slide showing the AF guidelines really in a nutshell, highlighting that the patient is at the center with all the various primary and secondary care healthcare providers around them, and the guidelines very much advocating a CC to ABC approach. CC is to confirm AF with a 12-lead ECG or a single channel recording, to characterize the AF using the 4S approach that we've talked about, and then having an ABC approach of ensuring that there is anticoagulation, and we think about stroke risk, of ensuring that we control the symptoms so that patients' quality of life is considered, and rhythm control, rate control are also considered and discussed, and then thinking about comorbidities and risk factors and tackling those for each patient that's in front of us. And
Faisal,
with that, I'll hand back to
what
you.
can I
So,
say?
thank you.
Yeah, what can I say, Faisal? That was a masterclass overview of the current evidence, and really brought us up to speed with the current guidelines in atrial fibrillation. I think the two things that stood out for me were really, the most important stakeholder in this whole piece is the patient, and we've got to have the patient right at the center of that decision-making process. But also, if we are considering intervention, I think it's really important to remind ourselves, you reinforced it beautifully, that the earlier you intervene, the better the outcome. So if you are going to if you're thinking a patient maybe benefit from an intervention, let's get that referral done early. Before I let you go until the discussion at the end, Faisal, you mentioned that you can't cure atrial fibrillation. So what you didn't do actually was define what you mean by a successful ablation. What does success mean in terms of an AF ablation procedure?
So that's a very good question. So when I say I don't use the word cure, a cure implies that you've done the procedure and the AF will never come back again. It's gone for good, and I would say that's not usually the case. And we know that as the heart ages, as I've mentioned, as the atrium dilates, the risk of atrial fibrillation coming back is there over time. Now, hopefully what we're doing by doing an AF ablation is actually minimizing that and actually maintaining normal rhythm for a lot longer. And so in terms of success rate and how we would define success rate, we would look to make sure that the veins, the pulmonary veins, are isolated as a first off procedure. And again, in those with paroxysmal atrial fibrillation, where we know the veins are the triggers of the atrial fibrillation, if we've isolated the veins, we know the outcomes are actually very good and the success rates tend to be quite high. We tend to quote here in Coventry a 70 to 80% chance of success at 1 year. And actually, for paroxysmal AF, we know the outcomes are around about that level. However, those with persistent AF, what tends to happen is that the veins, of course, are important, but then the atrium itself can become important in triggering and maintaining atrial fibrillation. And so if you're just isolating the veins themselves, you're not necessarily going to be preventing that AF from coming back if you have recurrent persistent, particularly if you have long-standing recurrent persistent, where other parts of the heart, the atrium, can become important. And we often will then, if they come back for further procedures, we'll make sure the veins are isolated, because they can often reconnect over time, and that just happens within the normal heart. But we will often then do other ablations within the heart, near the roof of the heart or the back of the heart. And there are certain areas that are a little bit more difficult for us to do ablations on because they increase the risk of complications. But really, in terms of success rate, our first off procedure is to isolate the veins to make sure that they are electrically sealed and there is a good pulmonary vein isolation, or PVI, done at the very first procedure. When they come back, to ensure that the veins are isolated, and if any further ablation or burning needs to be done, we then target that.
Thank you so much, Faizel, for that very clear explanation.
Pleasure.
Barry, if just stay on, Faizel, because we're going to have a discussion at the end. But Barry, if we can just bring you in now, if you don't mind, a very warm welcome to you. If you could just give us a very brief overview of your perspective of the guidelines, and in particular, if you can focus on how we can try to prevent those patients having those catastrophic AF-related strokes. What can we do more in this space?
Okay, thanks very much, Dr. Javaid. From my perspective, I think the first thing that we can do, and my name is Barry McDonnell, I'm a cardiovascular physiologist here at Cardiff Metropolitan University, but I think the first thing that we can do in our fight against AF-related stroke is to try and increase awareness and early detection, because I think this is the first point of contact by which the individual would be made aware of their condition and then be able to do something about it. The problem is at the moment that there's a lack of individual and population awareness about the condition, and early detection is first and foremost to try and to prevent these strokes. The more we can detect those of us that are, or the people in society that have AF, then the more we can do something about it. It goes without saying, and after a really nice overview from Professor Osman, AF categorically increases our risk of AF-related stroke. That goes without saying. But importantly here, and you can see on my slide, that approximately 20% of those who have AF-related stroke are only diagnosed with this AF at the time of when they present with stroke in the hospital or shortly thereafter. So it's really important, and like the case study you mentioned at the very beginning, we try to get early detection as soon as possible to maybe see if we can protect against that individual progressing to a catastrophic AF-related stroke. I've got some information from the AF Association and the screening survey, and I think it's really important to highlight here that the challenges that we have for diagnosis, and when we look at the AF screening study, we can see clearly that there's nearly 30% in those over 71 years. There's 41% sitting above 61 years of age. But quite staggeringly, we have 30% of those that diagnosed with AF are under the age of 60, which again is quite an important issue for highlighting that there's people out there that maybe not at the high risk in terms of epidemiological data, but are presenting with this high levels of AF under the age of 60. Importantly here as well is that we can see that those that are presenting and in the AF screening have received screening following symptoms. So symptoms have preceded those going on to getting a AF detection by the healthcare professional. But really importantly here on the right, at the lower right area here, is that 7% of those with AF had no symptoms at all. And I think this is a really important subgroup of people, again, out in the community that are asymptomatic, that are walking around without understanding that they are at high risk of AF-related stroke. And it's those individuals that we need to be really trying to focus on, as well as those in the older age groups which have a higher risk. But we can't forget about those with that asymptomatic and the cohort. So this is really important, and I think it was alluded to by Prof. Osman that this study here clearly shows that if you are asymptomatic, that doesn't rule you out of having an increased risk of having stroke and death. This study here quite clearly shows that those that are asymptomatic after a follow-up of 6 years had a similar risk of stroke and death compared to those that are symptomatic. So having no symptoms whatsoever does not protect you from the risk associated with AF. So I think that's a really important point that I think awareness needs to be driven upon and worked upon, and will allow us to understand the population to understand that you need to take this seriously if you present with or detect with AF. And I think awareness is the key issue here. In patients with AF, and again, this comes from the AF Association survey that they've done, 37% of those with AF were unaware that AF actually causes clots. 40% were unaware that AF leads to a stroke. And again, 48% are unaware of the reasons for anticoagulation. So I think we have a real job to do in terms of awareness and providing knowledge to the population of patients and also the wider community about AF awareness, understanding the risks associated with it. And it was only through that we can really address the risk on a population level. We know that the AF Association have written this white paper document to try and address these issues and try and bring forward some of the key focal points for how they're going to address AF-related stroke. First one being prevention and awareness, where understanding AF is at the forefront, and what you can do potentially to prevent or to reduce your risk of AF-related stroke. Then comes detection. So again, it factors in and it aligns with the Public Health England and the NHS 10-year plan of trying to increase early detection rates in the community and making every contact count. Because if we have people that are going to a healthcare professional for some other reasons, if they're having their blood pressure measured, for example, then why not have AF detection measurement done at the same time to hopefully catch some of those population that may be unaware that they have AF. That then leads to protection. Once you've been detected with AF, you can follow the clinical guidelines like Prof. Osman has clearly identified and alluded to. And that leads to then the overall perfection of correction and perfection of the AF for individuals. Now, through correction, we can improve modifiable risk factors, like Prof. Osman said, one of the key ones being improve to reducing levels of obesity, alcohol consumption, smoking. All of these risk factors can be helped and can be modifiable. And that will then lend itself to the perfection, i.e. the maintained engagement with the healthcare provider to manage the condition for the patient. And we have all this in the AF Association white paper document that is there, clearly identifying prevention, detection, protection, correction, and perfection of all those key facets. And I think that initially is the first step that we need to take to try and increase the awareness and increase early detection to try and get a better handle on this AF in the community. And that's back to you, Dr. Javaid.
Thank you very much, Barry. Great messaging. Really important call to action. I mean, I think the AF Association have done so much actually in terms of driving awareness and greater sort of prioritization of AF detection and management, particularly in primary care. So I think now's would be a good time for another poll question, if that's all right. I'm not sure if that can be put up on the screen. It'd be really interesting just to gauge the sort of level of understanding in the audience in terms of what causes AF to lead to AF-related stroke. And you should have some options coming up at the bottom of your video player. And I can see the second option. I'll just leave that on for a few seconds, actually, while we're getting people to mull over those answers.
I think from this perspective, Dr. Javaid, that it's very important to understand that AF doesn't have just one particular mechanism why it drives AF-related stroke. It has a multitude of factors that end up driving risk, and it's important to take this holistic view in terms of and understand the reasons why this is particularly happening and why these patients are at higher risk for awareness, but also for potential future management.
I totally agree, Barry. In fact, you could argue that all of these responses here available are all interlinked in the patient, and you've got to have this broad sort of holistic strategy to try and address the issue. But most of the audience are putting down increased thromboembolic risk. So I guess that's the traditional way of looking at how AF causes a stroke. You get this mechanical stasis of blood within the atria, particularly within the left atrial appendage. The stasis causing the clot to develop, and that clot is almost a ticking time bomb that can break off, go straight into the left ventricle aorta, and it usually goes straight up the carotids and blocks a major artery. But clearly there's a lot more complexity to it than just a sort of mechanical mechanism that we've just described. So, Barry, should we move on to the next part of your presentation? We've sort of mentioned that it's the early detection of AF that is probably the biggest challenge that we have to address if we want to make a meaningful impact. So give us some strategies as to how we can improve that early detection and awareness for our patients.
Just before I do, in relation, just to quickly address some of the poll and this holistic view that we were just talking about, I think the audience are quite right. The thromboembolic risk is obviously a major issue, and again, that's the origin of that is back at the atria and the stasis that creates the clot formation. But I think it's really important to also identify that this disruption in hemodynamics doesn't just sit in the chambers of the heart, and that, as you quite rightly said, gets transmitted right the way into the ascending aorta, into the carotid, and up right the way through and transmitted to the brain. And it's that insult or hemodynamic instability and turbulence in flow that we can see that gets all the way to the brain. And one of the slides I have here is you can do a transcranial Doppler that allows you to see that the bottom left of your screen will see that this is the flow profile going into the brain. So again, this is highlighting that the hemodynamic changes associated with the atrial fibrillation originating back at the heart is actually transmitted right the way through to the brain. And it is really important because it determines the type of blood flow that gets to the brain, but it also back downstream in the carotid. If there's already a clot that has formed and adhered to the edge of the arterial wall, this turbulent flow has got a greater chance of dislodging this clot, and then that gets transmitted to the brain. And this is where I think hypertension also has a role to play in being the driving force, the mechanical energy that then combined with it will really drive on and increase this risk of clot disruption from the arterial wall and being transmitted to the brain. But in terms of hypertension itself and AF, in terms of the risk of stroke, we know that there's a lot of similar risk factors that are associated with it. Obesity, we know smoking, sleep apnea, but also endothelial dysfunction. When you have a turbulent hemodynamics that leave the heart and go towards the brain, you also affect the endothelial function of the arteries that this blood clot or blood pressure and flow gets transmitted through. Now, if you combine those risk factors with hypertension, then that exacerbates the risk of having your stroke. But combine it with atrial fibrillation, you have a double and a deadly combination of thromboembolic risk originating from the heart, from the atrial fibrillation, combined with the high pressure, that will then increase your risk of developing and transmitting this highly problematic clot to lodge in the brain and therefore create the risk of the stroke. So I think the combination of hypertension and atrial fibrillation is very important to consider, and I know it's been proposed in many studies where hypertension itself is a precursor for development of new onset AF. So it's important to try and keep that in mind. You mentioned then in your question what can be done on maybe a more community-based global level to try and address this risk and to try and increase awareness. Well, we, as part of the May Measurement Month Blood Pressure Awareness Campaign, have been trying to address the blood pressure inequalities, the understanding of undiagnosed high blood pressure in the community. This year now we're pairing up with AF Screen Global Campaign to try and combine, when we're doing some blood pressure measurements, to do an AF detection at the same time, highlighting previously that the interconnection between hypertension and AF is such a critical measure, and both together increase your risk of stroke. It's a perfect match to try and increase community-based detection. Previous years, what we've been doing, we've been trying, like you've suggested previously, we've been opportunistic screening of our early detection awareness campaigns that we've been doing have to try and reach out into the community to get more awareness, more detection of those walking around with high blood pressure. And as I said, this year now we're going to be moving into and combining this with AF Screen to try and prevent AF related strokes and detection, improved detection of AF in these communities. We've done a lot of promotion of this campaign through the Lancet, European Heart Journal, and we've tried to use these campaigns and using celebrity endorsements to try and increase this awareness even further. As Professor Osman has quite eloquently alluded to, these various different devices that are now on the market that will allow us to improve early detection. And again, it's critical that we're using devices that are being well accepted, they're valid, and they give us accurate readings. And again, with the complete device here at the bottom of our screen, we are going to be using some blood pressure measurements and AF detection at the same time, because the complete device has the AliveCore, the system inbuilt into it, which allows us to be able to measure blood pressure and AF in every participant that comes through. So this is where May Measurement Month and the AF Screen will come together, and using technology we'll be able to get this out into the wider public. Of course, we'll be adhering to the guidelines, and this early detection identification process, together with the May Measurement Month protocol, we'll be informing participants about the significance of implications of AF. So again, a lot of awareness in this perspective. We'll also be informing them of a structured referral platform, which has been advised and devised with clinicians, that once detected with the systems, that is considered possible AF until the arrhythmia specialist or the GP has actually seen the rhythm, like Prof. Osman has previously suggested. So this is not a diagnosis, but a possible detection of AF for future consultation. And there's a lot of resources that we've provided from AF Association, Arrhythmia Alliance, Knowing Your Pulse, and videos to how to go about doing this and understanding what your pulse means when you can palpate it, in addition to all our blood pressure awareness details and guidelines that we have for May Measurement Month. And at the end here, I guess I've got some resources here that people can click on and use for both the May Measurement Month campaign and the Arrhythmia Alliance AF Screening collaboration that will be undertaken. And back to you, Professor Osman.
Thank you very much, Barry.
Sorry,
that was
Dr.
fascinating.
Javaid. Apologies.
Yeah, sorry, that was fascinating stuff and really inspiring, actually. So if you just hold on for a few minutes while we introduce our next guest. So Lucy Gilbert, what a great role you have, innovation lead, working closely with Professor Osman. I guess we're now in an era of a much greater appetite for embracing innovation, not just in terms of technology, but new ways of working. So can you explain to us, Lucy, your experiences, particularly from patient experiences, actually, of using this new innovation from OMRON Complete, and its role in the self-management of atrial fibrillation, because I think this is really exciting study that you've been involved with.
Absolutely, thank you. And I agree. I'm fortunate. I love my job as innovation lead, and we work on a whole variety of different innovations. But yes, one of the current projects we're working on is around this evaluation of the OMRON Complete device. So as Barry touched upon, this is a fairly new device to market, which integrates a blood pressure monitor and single lead ECG. And it's used in conjunction with the OMRON Connect app to support data monitoring, tracking and sharing. So I think we've spoken a lot this evening about early detection, early monitoring. We've spoken a lot about single lead ECGs being able to use as initial diagnosis of AF, and this OMRON device allows for that early detection and that home monitoring, and it allows that 30-second measuring of the single lead ECG. So here at University Hospitals Coventry and Warwickshire, we have our innovation hub where we're set up to explore, evaluate and implement innovation. So we were approached by OMRON to work together with Professor Osman to do a usability and feasibility study into this new OMRON device with our patients and the quality of data that this device gathers. So our study has 3 arms. So the first arm of our study is very much around patients which are under the care of Professor Osman's and colleagues' arrhythmia clinic. So we are recruiting 20 patients who take this device home. They have it at home for around about 2 weeks, and we ask them to use it once or twice a day. They then return it and they fill in a questionnaire and take part in some semi-structured interviews with myself and my team. And we're really looking at exploring some information around their previous use of any self-monitoring devices, and the usability factors of portability of the device. How did they find the use of the app going forwards as well. Sorry, I just lost my internet connection for a second there. The second arm of the study is around those our patient and public partners who aren't under the care of a consultant. And I think this is where this study gets quite interesting, because we're looking at this device in terms of self-management for somebody who may have suspected or diagnosed AF, but we're also looking at this device of the app with people who perhaps don't have a cardiac problem or potentially don't know that they have a cardiac problem. And as Barry was saying, there's quite a high proportion of people with undiagnosed subclinical AF as well. So with these, we get people into the innovation hub, and we're recruiting around 20 patients to come into the hub and have a go at downloading the app and have a go with the device to then give our feedback again on very much the usability of this device. Then we're also exploring the clinical view as well. So once we finish recruiting to our study, we will be working with Professor Osman to find how he found the quality of data and what impact patients sharing that data with them could potentially have on their care going forwards. So we're about halfway through this study at the moment, and I've got some preliminary results that I can share with you this evening. So first up on user experience. So as you can see, people found the experience of using the device, connecting the device to the app fairly easy. We did have some patients which found it a little bit more difficult, but these were perhaps those patients which were not quite so used to using digital technology and not quite so used to using digital apps. We also looked at the experience of measuring their ECG and measuring their blood pressure, and probably not unexpectedly, people found it much easier to measure their, well, not much easier, but slightly easier to measure their blood pressure than they did their ECG. So I think everybody is very used to having blood pressure monitors. It's very commonplace to have blood pressure monitors at home, but it's this ECG, the single lead ECG, and the Alive Core technology, which is really new in this device, and people did find it easy to use. But I think some people, looking at the next slide, it was very unique for them to be interpreting this ECG. So whilst a lot of our participants really like being able to see their ECG and they get the live view of the ECG for the 30 seconds, it's interesting to see people are not quite sure how to interpret that. And I guess that links back to what Barry was saying around knowing your pulse and raising that awareness of AF. But I think most importantly, the participants that we've recruited to date very much see the benefit of having a device which does this combined measurement of both single lead ECG and blood pressure. And the patients under the care of our cardiologists really see the value of having both of those measurements in terms of monitoring their condition at home themselves. So we've got a little bit of a poll to pop up then. So alongside this very much quantitative data that we collected, we've done some in-depth interviews with our participants to understand and drill down further into their experiences and the benefits they found. So I think we've got a little poll just to ask the audience what you think the benefit would be to your patients of having this device that they have at home with them to self-monitor.
So guys, if you can just look below your video player again for the options, and just in the interest of time, if you can just give your responses as quickly as possible. We're going to overrun very slightly on this webinar, but it's been such a rich discussion.
Yes. So we've got a little bit of divide in there in responses.
Yeah.
I think it's interesting as well, and what we found in our data is that again, this differences between our clinical population and perhaps the non-clinical population, and whether you are using the device to monitor a condition or potential early detection of a condition.
Lucy, give an overview of the poll results and then some discussion on that.
Fantastic. So I think the majority of people there, it's around that reassurance and this device providing the reassurance to the patient population. And that's exactly what we found in our study to date as well. So if we move back over to the slides, you can see that our user feedback is falling into three categories. So the first theme that we're picking up in our feedback is that patients really like the convenience of the device. So they really like the ability to do that single lead ECG from the comfort of their home, and they're finding the device very easy to do to allow them to do that. The second theme is around patient empowerment, and I think patient empowerment is always a really key thing in healthcare, but patients are really liking the ability of the device to allow them to screen, and they like the ability to share results with their clinician as well. And we've already had some participants within our study that have taken that opportunity to get their heart tracings and to share those with Professor Osman, again, to get some additional reassurance from their doctor. Participants also like the device to allow them to manage their conditions. So they like that visual real-time output. And almost all of our participants have said that they would recommend the product to other patients to monitor the condition. And you can see on the right-hand side there just a few key quotes from some of our participants, which are very much focused around giving you peace of mind, given some assurance when their heart rhythm and their heart rate was normal, and liking the ability to save, download and share the data. So drilling down a little bit further into self-management then. So I think this is really key when we're thinking in the NHS very much around remote monitoring, around keeping people out of hospital. And our participants who are under the care of a cardiologist are all agreeing that they believe the use of this device would allow them to go longer between participants, and allow them to feel happier just having remote consultations with their clinicians rather than face-to-face appointments. So we've got a couple of patient stories from our study so far, from these patients that have had the device for a couple of weeks. So first up, we've got a 74-year-old woman who's had suspected AF and been under the care of our cardiologist for quite a while now. However, her episodes of AF haven't yet been captured, and she'll be the first to admit that her quality of life is impacted at the moment because she's frequently attending GP appointments, she's frequently attending hospital appointments to try and capture that AF in order to get the treatment that she'd need. She took the device home, very keen to use it, and she was able to have that device at home. And when she did start to feel unwell, she was able to quickly pop on that device and see what was going on with her heart rhythm. Our second patient story, we had a 63-year-old gentleman who's been diagnosed with AF, very, very good understanding of his condition, which is currently stable. And the device allowed him just to monitor his condition at home and to pick up on any deterioration early on. And he was very much, again, reassured by having this data. He was well educated about his condition, but the device just gave him that extra level of reassurance that he wasn't in an AF, he was still stable, and there was no need for him to get in touch with his consultant. So we've currently done one focus group with some of our patient and public partners recruited from our PPI groups across the hospital. And as I said, these are members of the public which aren't under the care of a consultant, and it's interesting to see the comparison between the two. So these are kind of the target population that could potentially be using the OMRON device because they've perhaps heard about AF and they just want to make sure that everything's okay, and they're that part of that 7% walking around with asymptomatic AF. Again, the themes that we're getting back from the device are very, very similar. They find it very convenient device, and they like the design and the portability of it. But as I say, these results are hot off the press, and there'll be more to come. But yes, I think this links in well with the discussions we've been having this evening around that earlier detection and around.
Well, thank you very much, Lucy. You're sort of slightly breaking up, but I think you've come to the end of your presentation. What an exciting innovation. What an era we're living in where we have these sort of technologies available for us. I think it's worth noting that the Alive Core, the single lead ECG component that is actually integrated in this device, has actually now been NICE approved. I believe it's the first single lead ECG technology that has actually got a NICE approval for the detection of atrial fibrillation. Look, guys, in the interest of time, I want just 3 or 4 rapid-fire questions. There's a lot of questions from the audience. If I can ask Osman, Professor Osman first. In primary care, we're often, some of us are reliant on the ECG interpretation of the machine interpretation. How far are we from being able to totally rely on that, particularly with artificial intelligence and machine learning technology? Or do we still need a clinician to confirm the trace is atrial fibrillation?
Thank you for that. Yes, that's a very good question. So I think the NICE approval that Alive Core got actually included its algorithm as well of AF, no AF, or indeterminate. So I think technologies can help, and they clearly have programs that are going to help us, and we are going to need help, because if we are going to go out and start screening people, we're going to be seeing a lot of people with a lot of traces. A lot of them understandably will be worried, and so we need to be able to answer the question. It will require a lot of resource. So these algorithms, I think, are helpful, are useful. A lot of the interpretation depends on the quality of the tracing, and I think it's important we let our patients and the general public know that the quality of the tracing matters. And I think we're getting there, but we're not quite there yet. I think very often there is interpretation that's needed, and very often a cardiologist may even need to look at it. Sometimes it can be very difficult, even for us, to know actually what is this atrial fibrillation or not. So I think the technology is moving, and you touched on AI, and artificial intelligence undoubtedly will help. And I know these companies and many other companies around the world are investing heavily in AI, and undoubtedly it will make a difference. But we will need that AI help because of the sheer volume of traces that we will have to look at. So I think we're getting there. We're not quite there. And I think we still need the human eyes often to have a look at the traces that are sent to us.
So the machines are getting better, but they're not quite at the level of a cardiologist to review that ECG. Another question, please, for Barry. You mentioned this sort of interlink between blood pressure and AF. Just very succinctly explain to us why it's such a particularly bad combination for AF-related strokes, Barry.
I think it's really important to highlight that when you have a hemodynamic insult like your AF that you're potentially persistently in, that you have it increases your hypercoagulability and your chance of having a thromboembolic event. But that thrombus or the clot that's formed in a higher pressured system like high blood pressure will increase its formability, but also increase its risk of getting transmitted to the brain. If it's inside and it's aligned to the inside of the arterial wall, then a higher turbulence, higher pressure will drive this increased risk of it being dislodged from the inside of the carotid, for example, and then that gets transmitted to the brain. So this interconnection between high blood pressure, increased turbulence, and the clot itself is a really bad combination that presents to the ischemic stroke that will be the result for that individual.
Great, thanks Barry for that. Prof, again, a question to you. You know, we've had unprecedented times in the last couple of years. Lockdown has impacted on a lot of people's lifestyles. Dare I say it, alcohol intake in some patients has been more excessive than usual, shall we say. How common is alcohol-induced AF, and how much should we be hunting for or taking a very detailed alcohol history in some of these younger patients with AF? How common is that as a cause for AF?
Again, a very, very good question. Alcohol is, without doubt, can be a very important factor and a trigger in people who present with atrial fibrillation. And certainly the patients that I tend to see in my EP clinics, they're referred for consideration of an AF ablation. I try and spend a little bit of time with them. Obviously, we have limited time, but it's very important to highlight to patients that actually these risk factors, particularly alcohol and smoking, are things that the patients can do something about. And you're quite right, COVID has been difficult and has impacted the intake of alcohol, but it's very, very important that people who have atrial fibrillation, particularly those who are on therapies, antiarrhythmic drugs, or who've been considered for an ablation therapy, to recognize that actually it's very important that these adjustable, modifiable risk factors are tackled. And we here in Coventry are currently planning on doing a study looking at patient education and risk factor modification prior to AF ablation and after AF ablation, and hopefully we'll get some idea from that. But there is evidence, quite strong evidence now, that alcohol intake, in terms of controlling it, reducing it, is important in terms of outcomes of atrial fibrillation, particularly with regard to AF ablation, for example.
Well, that's a really good point. And similarly, I guess weight loss is also a really important determinant of successful ablation outcomes. Right, very last question. We often get mixed messaging about intense physical exercise and its impact on atrial fibrillation. Just very quickly, any member of the panel can chip in here. Good or bad for AF? Because we know that extreme exercise can often induce sort of paroxysmal AF, but in general, what's your take on patients who are wanting to do intense physical exercise with atrial fibrillation?
So again, another very good question. If I just answer, and I'll hand over to my panel members. In terms of the study we're planning here, we're looking at not only risk factor modification, but gentle exercise over a period of time, because you're quite right, exercise is important. There is evidence that actually gentle exercise is good for you. Doing a steady workout for longer can be a very useful thing. And again, relating to weight and weight gain and weight loss, the more activity, the more physically active you are, hopefully that will lead to a better body mass index. And we know that the higher your body mass index, the worse your outcome when it comes to AF. In terms of high intensity versus moderate or low intensity, again, there is debate raging about the benefits and risks of either. I tend to advise patients to do moderate levels of exercise. Patients know how far they can go and what they can do. And I always say to them, actually, go walking is often a very gentle form of exercise that you can do for a lot longer. So, you know, I would certainly advocate moderate levels of exercise.
Barry or Lucy, anything to add?
I would echo that in terms of the moderation of exercise, but we also know that exercise itself increases and lowers blood pressure in addition to the the risk for AF. So like Professor Osman mentioned about weight loss, but it improves the vasculature, improves everything that we need from a hemodynamic perspective. So again, I'd be a big advocate of the improving physical activity within moderation.
I mean, really, it's really the extreme endurance athletes, really, they're the ones that, Prof, you do see from time to time developing atrial fibrillation from that extreme endurance, but they're likely to be CHA2DS2-VASc 0 and be at low stroke risk.
Yeah, no, you're absolutely right. And I do see, we of course know about athletes' heart and people who do a lot of triathlons or marathons. And I see those patients in my clinic, and they come in, they're young, and all of a sudden they've had atrial fibrillation, and you do an echo and they've got some changes. The LV is a little bit dilated. There's a bit of hypertrophy. And I think in the old days, we sort of kind of dismissed it, but I think there's an increasing realization that athlete's heart is not quite as benign as we thought. And certainly patients who do a lot of this high-end training, very, very intense for long periods of time, putting a lot of stress on the heart, it may not quite be as benign as we thought. And actually, we certainly know that it's linked to atrial fibrillation.
Great. Thank you very much, guys. You've been, each of you have been a superstar today. Sadly, we've run out of time, but what a wonderful trio of presentations by our expert faculty. Let's now revisit our original case that I presented right at the beginning, this tragic young female patient who had every right to expect many good quality of life years ahead in the early stages of her retirement, tragically suffering an AF stroke, and now destined to spend her last few weeks or possibly months lying in a nursing home, not being able to speak, swallow, or move half her body, the worst possible outcome you can imagine for a patient. And tragically, this is an all too common scenario. We know that AF is responsible for around 1/3 of all strokes, but 50% of AF strokes occur in patients previously undiagnosed. In other words, as the first presentation of atrial fibrillation, stroke is really winning the race far too often. And we know that hypertension is a key risk factor. Barry has eloquently described how not only does it develop or assist the development of atrial fibrillation, but also independently increases the risk of stroke. I think having a portable ECG monitor integrated with a blood pressure machine is a wonderful marriage of technologies, a great innovation that can help address the huge burden of avoidable catastrophic stroke. I'm certainly going to be getting one as soon as I possibly can and deploying them in my clinical practice. And often premature stroke, is what happens in these patients. It's the premature nature of the stroke that is equally devastating, and it comes at huge costs, not just to the NHS, but of course social care and massive human costs. So I think by embracing this type of innovation, by being proactive, using technology like OMRON Complete and deploying its use appropriately, we have a wonderful opportunity to add a huge number of years to life, as well as a massive amount of life to those years by detecting more AF opportunistically as really part of routine clinical practice. I'd like to thank OMRON for kindly sponsoring this webinar, Radcliffe Cardiology for hosting it, our tremendous expert faculty for their great insights, but most of all you, the audience, for your very kind attention and interaction. Goodbye and have a lovely evening.